Thank you all. I hope you're ready. I just want to say, so anyway, so intensivist and a nephrologist walk into a bar and they've had a long, hard day at Joburg Hospital. And they order two nice ice cold beers. And the barman says to the intensivist, "I'm sorry, I can't serve you." And he says, "What do you mean?" He says, "Well, you might become fluid overloaded." Anyway, so I'm a nephrologist. Dr. Tilley is an accomplished intensivist. I don't know how many of you published a textbook when you were medical students, but he did. He is interested in a very difficult field in medicine, that is the field of evidence-based informatics and then the development of medical protocols. This is tough work, I can promise you. I enjoy his talks very much. We're good friends, and I hope you will as well. I'm sure it'll be informative and definitely thought-provoking. Welcome, John.
Thank you. Good morning. I'm talking about fluid therapy today. Is the keyboard on the... behind you. Yeah. All right. Is it working?
Yeah, just click on that. The keyboard will work now.
All right. So just sort of some of the things we're going to be talking about today, that colloids are not necessarily better than crystalloids, that the notion that albumin can pull fluids out of your interstitium into your blood vessels is incorrect, and that capillaries are one-way streets for fluid. They filter fluid, but the fluid does not return to the capillaries as we have been taught in the past. And we're going to go through this by looking at the Starling equation, the glycocalyx, what fluid choices you've got, and then how that applies to real-world application. So just to have a look at the classic Starling principle, is this still what is taught in physiology? So the idea is that you start off with a high hydrostatic pressure, which is the blue line, and then that's at the arterial end, and then as fluid gets filtered out, the hydrostatic pressure drops down, and then the oncotic pressure starts going up as you have less fluid in the vessel, and the force is then reversed. And in the venous side of the equation, the fluid then gets pulled back into the blood vessel, and things remain in balance. And that this really has been the prevailing theory of how fluids work in the body for over 100 years. Starling described this, I think, in 1896, and it's taken a long time for somebody to show that this is in fact not what happens. So in 1987 was the first seminal work that came through, which is quite a long time ago, but what these folks basically did was to plug some values into the Starling equation, and they then calculated on the amount of fluid that should be filtered. And according to the Starling equation, you should be filtering about 8 to 10 liters of lymph a day, which is clearly not what is happening in your body. So the question then arose, if there's such a difference between what the Starling equation predicted and what is actually happening, where did all of this fluid go? And there's really only two possible explanations for that. The first explanation is that the fluid wasn't filtered in the first instance, so the amount of fluid leaving the vessels into the interstitium never occurred, or that there was some sort of massive resorption of fluid into the venules, and that accounted for the balance. And in both of these instances, we have had some new knowledge. So firstly, it's well established that fluid does not return to the venules in the capillary beds. So once fluid leaves the arterioles, the capillaries, into the interstitium, that is where it remains. And the only way for the fluid to get back to the circulation is via lymphatic flow. So there is no return of fluid to that. So just to remind us about the lymphatic flow, about 50% of the lymphatics get absorbed in your regional lymphatics, where you've got lymph nodes. The lymph nodes are essentially part of your intravascular space, they are freely permeable to fluids, and the lymph returns to the circulation there, and the other 50% returns via the thoracic duct. So if we say that fluid is not absorbed by the venules, and that the only option then remains to explain the lack of lymph formation is that the fluid was never filtered in the first instance, and this really requires an understanding of something called the glycocalyx to explain. The glycocalyx was a missing piece in the puzzle for many years. It's surprisingly large, almost the size of a red blood cell, which is the surprise being that it's taken so long to see it. Just to remind you what the glycocalyx is, it's a mixture of mostly proteoglycans and plasma proteins. You can think of it as sort of the velvet, a Velcro of your blood vessel. It holds everything together. And if we had to look at a schematic of that, this is a very important picture to try and understand how fluids work in the body. You don't have a pointer button, Charles? No.
Sorry, you can use the arrow.
Does it work?
Control.
Oh, there it is. So this is the inside of the vessel, and this is your glycocalyx. And what happens is that the glycocalyx forms a subglycocalyceal space over here. And the important part about that is that there are proteins in the lumen of the vessel which exert an oncotic pressure, but in the subglycocalyceal space there are no proteins. And then you've got proteins again in the interstitium. So the traditional view that Starling put forward was that there's an oncotic pressure which is established between the inside of the lumen and the interstitium, and this is what pulls fluid across outside to the outside of the vessel wall. But in fact, the reality is that the oncotic pressure is between the lumen of the vessel and a space where there's no protein, so that the pressure gradient, as we'll see in the next slide, is in fact much higher than we initially estimated. One question that one can ask is, why do these proteins over here in the interstitium not just diffuse back into the subglycocalyceal space? And the answer for that really is that the fluid that is moving through these tight junctions, the velocity of that is sufficient to keep these proteins over here and to keep this space over here relatively protein free. So then, if we look at the Starling equation, this here is our oncotic pressure, and we can see that the original equation measured the oncotic pressure in the plasma vials minus the oncotic pressure in the interstitium, and really the revised Starling equation changes that from the plasma to the subglycocalyceal space. And if we were just to plug in some arbitrary values here, we can see that the pressure would change from 28 minus 10 to an arbitrary value of 18 to 27. So it is dramatically higher. And the fundamental concept that you need to understand about how fluids distribute in the interstitium is that there's a hydrostatic pressure that forces the fluid out of the vessel. Once it's out of the vessel, it can't return to the vessel except via lymphatics. So the fluid will leave the vessel, and the main determinant of that is hydrostatic pressure. As you increase your hydrostatic pressure in the vessel, more fluid will leave the vessel. This hydrostatic pressure is opposed by an oncotic pressure. So the higher your oncotic pressure, the less the effect of the hydrostatic pressure would be, but the oncotic pressure is there solely to oppose the hydrostatic forces. The oncotic pressure in and of itself cannot pull fluid back into a vessel. So if we were then to extrapolate this, then it would become clear that the movement of fluid really is dependent on the pressures in the vessel. If you've got a low pressure situation, so for instance, if you've got a patient who has hypovolemic or is vasoconstricted, there is very low pressure in the capillary. So it doesn't matter what fluid you put into the capillary at that stage, it will remain in the capillary because there's no hydrostatic forces which are pushing the fluids out of the capillary. So if you've got a patient who is hypovolemic and you put fluid in, you can even put dextrose water in, which we will talk about a little bit later. The fluid will remain there until the hydrostatic pressure starts going up, and then it will start filtering out of the vessel. And this is an important concept because it means that our original paradigm, where we thought that colloids stay in the vessel and crystalloids get filtered out of the vessel based on the changes in oncotic pressure, is not a valid well, it's not an invalid concept, but it's an oversimplification of what happens. So in a low pressure situation, it doesn't matter what you put in the vessel, it will remain in the vessel. In a high pressure situation, the situation changes, obviously, because as the pressure in the vessel starts going up, the filtration out of the vessel will increase dramatically, and almost all fluid, both colloids and crystalloids, will leak out of the blood vessel. So if we look at this, there's a concept of a J point, which was described by a father and son, Woodcock and Woodcock. We can see that on the schematic here. So in a patient who is normal volemic over here, as you increase the amount of fluid in the vessel, because the pressure is not increasing in the hypovolemic patient, there's really very little change in the filtration. You then reach a point where the pressure in the vessel starts going up, and as the pressure starts going up, the filtration will go up in a linear fashion after that. So that all assumes that a patient has got an intact glycocalyx. The glycocalyx is able to establish the oncotic gradient between the lumen of the vessel and the subglycocalyal space. The problems come in critically ill patients when the glycocalyx becomes damaged. And if your glycocalyx becomes damaged, which is unfortunately a common occurrence and surprisingly easy to do, then the entire homeostasis becomes disrupted. So just to have a look at what can damage the glycocalyx, sepsis, trauma, hypovolemia in and of itself will damage the glycocalyx, as will hypoglycemia. So fluid therapy becomes harmful the more you give. And if you give fluid therapy to a patient who is already overloaded, we will induce glycocalyceal dysfunction and cause further damage to our situation. So if you've got a damaged glycocalyx, then it doesn't matter what fluid you put into a blood vessel, the fluid will leak out. The concept of a colloid remaining in the blood vessel and a crystalloid moving across is, as I said, an oversimplification, but in a damaged glycocalyceal situation, it really doesn't make any difference what you're putting into the blood vessel. It will distribute into the interstitium. Once again, just a picture here. You can see in line with our new understanding that there's only filtration out of a vessel. There is no absorption of fluid, and that the filtration increases as the pressure in the vessel goes up. So the question is then, can we measure damage to the glycocalyx? And the answer to that is experimentally we can. So there are some biomarkers available, and the area under the curve for these biomarkers correlating with mortality is relatively good, and it would be a useful thing for us to have, hopefully, in the near future. All right, just to talk about albumin. Albumin is our main protein exerting oncotic pressure across the vessel. Just to remind you, the majority of the albumin is in fact in the interstitium, and there's a little bit of filtration of the albumin from the fluid into the interstitium. There are various mechanisms for this. And the interesting thing about the albumin store in the tissues is what you see for instance, in patients with hemorrhage, is during the early phases of hemorrhage, what would happen is your lymph flow would increase, and the lymph flow would increase the return of albumin from the interstitial space back into the circulation, and would provide sort of an auto transfusion of albumin, and increase the oncotic pressure in the vessel. So that is just the sort of the understanding of the basics of fluid therapy, and how we should think of it. The idea really is that one should give fluids up to the point where the pressure in the vessel starts going up, and once that happens, then fluid therapy should stop, because after that everything becomes harmful. So moving on to the next part of our talk, we've got the great saline versus balanced solution debate. Just to remind you, I've put up here the compositions of the fluids. So normal saline has got a very high sodium and chloride content. How it got its name normal is not entirely certain, because it's not a very normal fluid. The popularity of saline stems from the great cholera epidemic, where it was used as a first for resuscitation. The only thing that is, I suppose, normal about normal saline is that the osmolality of saline approaches the normal osmolality of the serum. But you can see that the quantity of sodium and chloride in normal saline is really fairly dramatic. Balanced solutions are very similar to plasma. So the chloride content is much less, and the sodium is less as well. The SID is the strong ion difference, according to Stewart. I don't know if you are familiar with the strong ion theory of acid base. I think the uptake has been mostly in critical care, and less in other specialities. The idea is that in your body you've got strong cations and anions, and these are usually in balance, which computes to a difference of around about 40 in the body. And as you start lowering your strong ion difference, then what needs to happen is your body needs to compensate, and it compensates by manipulating bicarbonate to try and keep your strong ion difference stable. So the main application of Stewart's theory really has been in explaining the occurrence of an acidosis, which occurs as you give patients saline, which is a well described phenomenon, because the strong ion difference drops, and you need to then drop your bicarb to compensate for that. So the crystalloid versus the balanced solution versus saline debate is like one of those debates in critical care that revolves around the use of steroids. It's been carrying on for a long time, and there's really no clear data one way or the other. If one had to look at the sort of the overall cumulative evidence for this, mortality in individual trials is not particularly convincing, but if you take all the trials together, there may be a small benefit. In terms of acute kidney injury, I think that there's reasonable evidence that balanced solutions are better at preventing acute kidney injury. It's probably the chloride which is toxic to the kidney, and what happens with the balanced solution is that the chloride content is dramatically lower, and that there's less kidney injury from that. And we've spoken about the hypochloremic metabolic acidosis, which is not uncommon with saline use, and I think out of the trials, that is the one thing that is universally prevented with the use of a balanced solution. If one looks at special populations, then In sepsis, there may be a little bit of benefit in adult patients. The benefit seems to be stronger in pediatric sepsis. Traumatic brain injury, the balanced solutions were less useful here because there was a concern that they would increase cerebral edema. So the normal saline likely remains the fluid of choice in patients with cerebral edema. And then in DKA, there has been some data which suggests that the acidosis in DKA resolves quicker with a balanced solution. Just to remind you that all the different crystalloids are not the same. So once you've given a patient normal saline, the saline will distribute across the evenly amongst the extravascular compartment. The extravascular compartment would comprise of the extracellular compartment, which would comprise of the intravascular compartment and the interstitium, and you would then get back to about 25% of your saline staying in the blood vessel. The rest of it will distribute into the interstitial space, generally not into the intracellular space because that is governed by your sodium potassium ATPase pump. Dextrose water, however, distributes evenly across all compartments. So an average person has got 42 liters of fluid, and if you give a liter of dextrose water, that will be a liter into 42 liters. Your plasma volume is about 3 liters of the 42. So in general, once you have given a patient a liter of dextrose water, about 80 or 100 mils of that will stay in your blood vessel. This makes dextrose water an entirely unsuitable fluid for fluid resuscitating patients. It is a great fluid making you very edematous though, because it goes across all compartments. I'm not sure what the current regimen is that is being used for DKAs. Certainly when I was a student, which is now many years ago, there was a regimen where one would run a fluid. At that stage, I think it was mostly saline, until the sugar got to a certain point. And then when the sugar got to a certain point, then you would switch to dextrose water, and you would then use dextrose water as an alternative. One sees that this is a situation which is fraught with problems. The reality is that the correct way to manage fluids in the patient with a DKA is really to address the two primary concerns, and that being that patients with a DKA have got fluid deficits in two areas. The one would be that almost all patients with a DKA would vomit. That is the defining feature of a diabetic ketoacidosis, and really what brings patients to hospital more than anything else. Also part of the reason as to why patients with a DKA present sooner than patients with hyperosmolar coma. But the vomiting would then just be a normal fluid replacement with a crystalloid. So these patients should have a crystalloid, probably a balanced crystalloid, running at a rate at which one would normally give to patients to replace the fluid. At the same time, these patients have been hypoglycemic for some time, and the hypoglycemia would induce a free fluid loss via the kidneys. So the patients would, in addition to an intravascular depletion of fluid, have a free fluid deficit. So one should run dextrose water at the same time. So our practice at our hospital is for the patient to have 2 drips running at the same time. In the one drip we put a crystalloid, and in the other drip we put dextrose water. We try and keep the sugar as high as possible, and we give a maximum amount of insulin on an hourly basis. And in general, our time to resolution for acidosis from a DKA is in the region of about 3 hours, even if patients present with a pH of less than 7. Fluid in itself is very useful in DKAs, and you can get a long way in terms of fixing your DKA just by giving a patient a fluid. Obviously, insulin remaining the primary choice. A bit off topic, but related is the use of dapagliflozin and related drugs, being the side effect, the complication of euglycemic DKA. I don't know if you've seen that. It's a very real thing. It does happen. If one looks at sort of experimental data around diabetic ketoacidosis, one can extrapolate to this, and really what one needs to develop a diabetic ketoacidosis with the use of these drugs is a combination of two things. You need to be fasting and hypovolemic, which is not an uncommon situation if you're going to go for endoscopy or you're waiting for theatre. And these are really the cases where we have seen this happening. So you really should advise your patients that who are taking drugs like dapagliflozin that this is a drug for well eating and drinking patients. As soon as you become unwell or you stop eating or drinking, you must stop the medication. All right, now just to have a look and see what happens with albumin. Albumin has been a firm favorite in terms of pulling fluid back into the blood vessel. But as we have established, there's no fluid moving from the interstitium back into the blood vessel. It's a one-way street into the interstitium. Just to have a look and see what happens when we give patients albumin. So there's no doubt that when we give patients albumin, the oncotic pressure in the vessel will increase. But just to remind that the oncotic gradient is between the vessel, the inside of the vessel lumen, and the subglycosyl space, not the interstitium. And in a normal functioning glycocalyx, the oncotic pressure in the subglycosyl space is already 0. So the relative benefit of giving albumin to these patients is not great. If you give 20% albumin, which would raise your albumin substantially more than 4% albumin, there is a possibility, although it's not well illustrated, that it may pull fluid from the subglycocalyceal space into the vessel, not from the interstitium, actually from inside the vessel into the lumen of the vessel. The quantity of that is estimated to be probably about 500 mils. But what happens is that as the fluid then moves into the lumen of the vessel, you will dilute your oncotic pressure in the vessel, and it will all go back to the way that it was. So it is not a mechanism. So generally speaking, in patients who receive albumin, you are unlikely to make any significant difference to their edema, because the edema is not governed by a low albumin content in the blood. So we were then asking common situations like heart failure, what causes the edema and heart failure, and clearly we've got an increased pressure in the vessel, and that will result in increased filtration. But really, for you to develop edema, because we have stated that that the lymphatics is what removes fluid from the interstitium, it would mean that for you to get edema in any person, it would imply that there is a lymphatic dysfunction. And this can occur in a number of ways. There could either be a problem with the lymphatics in and of themselves, and we know that in diseases such as heart failure, there's definite dysfunction of lymphatics, so that your lymphatic drainage is lower than in healthy patients, or the lymphatics just become overwhelmed. There's a finite limit to how much fluid the lymphatics can drain, from your interstitium. In cirrhosis, we have a similar situation. The ascites in cirrhosis is mostly a lymph which is leaking from the capsule of the liver. You can also get in the mesenteric bed, you can get increased pressures there conducted back from the portal hypertension, and in both of those cases, it is difficult to fix with albumin alone. There's a big role for albumin in liver disease overall, but the benefit of albumin in these patients is not necessarily via increasing your serum albumin. Albumin has got many other benefits that may account for the benefit that we see in diseases such as hepatorenal syndrome. So when we prescribe fluids are a drug, so we need to apply our usual principles as to which fluid we're going to choose, how much are we going to give, when to start and when to stop. So when we see a patient and we need to decide if the patient requires fluid, this can be surprisingly difficult, especially in critically ill patients. I think we have firmly established that the central venous pressure is of no benefit in this. What we hope nobody is giving fluids based on a CVP anymore. The reasons for this are multitude, but at least to say that many patients who are critically ill or in ICU have got respiratory dysfunction, have got hemodynamic alterations. In any patient who's got any degree of respiratory dysfunction, you're going to get large swings in your intrathoracic pressures. This is either going to drop your CVP or raise your CVP. Then we have a firm favorite of the cardiologists is the IVC diameter. The last time I checked, the SVC and the IVC were connected to each other. If we've all decided that a CVP is of no value, then I'm not sure how the IVC will be of value, because surely measuring the IVC diameter is just a visual representation of the pressure in the vessel. It is really a worthless measure. You're being led down the garden path. We must forget about this. What is of value is a fluid bolus. So you give your patient a fluid bolus, and the fluid bolus will tell you if the patient is or is not responsive. And you can give a fluid bolus in one of two ways. You can either give the patient fluid, or you can auto-transfuse the patient. So just to remind you, if you want to do a passive leg raise, this is how you do it. You have to first sit the patient up at 45 degrees. The idea is that you drain some of your splanchnic fluid into your legs to make sure that your legs are adequately filled with fluid. You then have to flip your patient the other way around to get the legs in the air, and then you do your observations, and then you want to turn the patient back again to see that things go back to the way that you started before you tilted the patient. And really the issue with both passive leg raise and with giving a fluid bolus is, how do we know what constitutes a positive effect? So if you've got invasive monitoring, such as cardiac output monitoring, that really is well validated. So we know that if you have an increase in your cardiac output by more than 10%, then your patient's fluid responsive. But the reality is that the majority of patients don't have invasive cardiac output monitoring. So we then have to start using surrogate measures. And if we start using surrogate measures such as your pulse pressure, then it starts falling apart a little bit, and the value is not as great. So it remains something which is difficult to do. I think that we are keen on lactate in ICU, where we have see what happens to your lactate after a fluid bolus, although that's not well validated either. But the reality is that knowing when a patient needs fluid is not necessarily an easy thing. In critically ill patients, the two strongest ways of knowing whether patients need fluid really is with stroke volume variation. And the basis for that is that when you breathe in and breathe out, your pressure in your chest would change, and that would result in changes in your stroke volume. So when you breathe in, you will have increased venous return, your pressure in your chest would be high, your stroke volume would drop a little bit, and when you breathe out, then the opposite would happen. And obviously, the bigger the variation would correlate with a fluid deficiency. The problem with that is that for the test to be accurate, we need to make sure that we are taking adequate breaths so that we can get adequate fluctuations in our intrathoracic pressure. You need to be in sinus rhythm, and generally this requires a patient to be on a ventilator. There are some papers looking at doing stroke volume variation in patients that are not ventilated, but the data is not strong on that. It is always interesting walking through some hospitals where you see patients on non-invasive cardiac output monitoring having their lunch, and one wonders what people make of that. The module that we are about to start using is a dilution method called PICO, which gives us a total lung water and global end-diastolic volume, which also correlates well. But in general, if your patient is clearly dehydrated, you can give fluid. But as soon as you think that the dehydration is better, then stop the fluid. It's really important to know that fluid is harmful. Once again, stepping back from general practice into critically ill patients, I think that there's generally an underappreciation of the harm that fluids do. Patients that are ill in ICU, that are hemodynamically unstable, requiring dialysis, at the best of times, Professor Paget can get a liter or a liter and a half of fluid off the patient per day before things start becoming unhappy. If we look at the general feeds that you give to a patient, it's usually a milliliter per kilogram per hour. So the majority of patients would be getting about a liter and a half of feeds per day. So in an ICU setting, we can only really take off what we are putting in. And if you have spent the first week pouring fluids into a patient, it is impossible for us to get those fluids off. I mean, there's just not enough stability for us to do that. And there's clear evidence that that excess fluid results in worse outcomes. And the reason for that is really not complicated. So if we look at the macro circulation, you have got your arteries, which are able to auto-regulate flow up to a mean arterial pressure of about 60. So once your mean arterial pressure is above 60, manipulating your arterial pressures above that is not going to improve your circulation much. But then obviously once you hit the arterioles, from there, the perfusion from there into the veins becomes a gradient. So your perfusion to your organs with a mean arterial pressure above 60 becomes solely dependent on your venous pressures. And in patients with high venous pressures, you obliterate the gradient in your organs and your organ perfusion decreases. So if you have patients that are markedly edematous with a lot of interstitial fluid and have high venous pressures, your organ perfusion decreases and you compromise your organ function. So if we then had to summarize what we want to take away from today's talk is that if your capillary pressures are low, if you have bled out or you're hypovolemic for some reason, it really doesn't matter what fluid you put into the vessel, it will help the patient. I think that the world has sort of turned against colloids to a certain extent. I think the enthusiasm is much less than it was 20 years ago. But generally, crystalloids are the replacement of choice, and we would generally choose a balanced solution unless your patient's got a head injury. Once your capillary pressures start increasing, though, it really doesn't matter what you put into into the patient will leak fluid into the interstitium. And this is the point at which fluid therapy should stop. If you take a septic patient, this really is the worst of all situations, because you have vasodilation. The vasodilation causes venous congestion, so you've got high venous pressures. On top of that, you've got a glycocalyx, which is not functioning, so the fluid is freely filtered out of the vessels. And in a severely septic patient, probably only about 9% of any fluid that you put into the patient stays in a blood vessel. You're chasing your tail. You are much better off with a septic patient to give the patient a vasopressor. And what the vasopressor will do is it will do two things. It will firstly constrict your vessels. By constricting your vessels, it will drop the pressures in your capillary beds and will decrease the filtration of fluids out of the capillary beds, and it will restore the normal physiology. When you've got glycocalyceal dysfunction, there is really nothing that one can do about this. Certainly, giving patients more fluids in this circumstance is not going to make things better. And really, the bottom line is that if you are edematous, then you are fluid overloaded. And giving patients that are edematous fluid is not going to help anything. The idea that you are intravascularly volume depleted, but edematous, well, we wouldn't say it is entirely unfounded in physiology, but certainly you are not going to improve that by giving fluid. So even if you're thinking the patient is intravascularly volume depleted, if your patient is edematous, giving more fluid on top of that is just going to make things worse, and you should stop fluid therapy in that circumstance. That's it.